Welcome, friends, again. Today I'm going to talk about stress ulceration of the stomach. Uh, Now, this is based on the request of one of my students to explain what stress ulcer involve and the clinical significance of that and its management. Stress ulcer comes with a variety of names, so it could be called stress gastritis or erosive gastritis or hemorrhagic gastritis. Now, these patients do not come from home with symptoms relevant to upper GI bleed. They are usually in patients with a major problem, and I will show you in a minute. How do we find about them? They usually are under a major stress. This problem in particular can be quite serious, can lead to severe form of bleeding, which need blood transfusion and further interventions. Um, the patient will either vomit blood or they will have coffee ground material in the nasogastric tube that they already have because they are hospitalized and had major intervention. They could have a bout of melena, or it is manifested by dropping in the level of their hemoglobin. And then we start looking for the source of that bleeding, which is usually GI related. Now, the main causes that will lead, or the clinical situation where you would worry about stress ulceration, are patients who are involved in major issues such as severe sepsis, whether it's related to a perforated viscus or they just had recent anterior resection or a gastrectomy and they leaked, and they are usually in the intensive care unit. Patients who are involved in multiple injuries, major trauma that needed intervention or massive blood transfusion. Patients who are admitted to the hospital with severe necrotizing pancreatitis. Patients who have extensive burn, more than 30% of their total body surface area. Those who had major surgery in relationship to their upper GI or rectal cancer or other for cardiac surgery or other major stresses. Also, in particular, patients with respiratory failure who were admitted for that reason to the hospital could develop gastric erosion as a result of the hypoxia. So gastric erosions and upper GI bleed from that do occur usually under these scenarios. Now, in general, how do we diagnose that? Once there is a suspicion, particularly if the patient is hemodynamically unstable or they have overt bleeding or their hemoglobin keeps dropping and they need blood transfusion, then we go endoscopically and have a look inside the stomach. It's not an ulcer similar to the duodenal or classical stomach ulcer. It's usually appear in the form of linear, multiple, superficial erosions, and they often affect mostly the fundus of the stomach, or at least they do start in the fundus of the stomach, which is the acid-secreting area, and then they do extend distally toward the antrum. They're always superficial in their nature, unless there are or there are exceptional situations where an artery could be invaded and then they could bleed from an arterial, significant arterial branch of the left gastric artery usually. When you look in the stomach, you'll see coffee ground contents or flakes of dark brown altered blood in the stomach. And if you biopsy these lesions, typically the pathology will come back as ischemic coagulative necrosis of the mucosa as a result of hemodynamic instability. These patients will become hypoxic, and they have reduced perfusion of all their organs, including the gastrointestinal tract, and as a result of that, the pathology of erosions will start. So we have to explain the sequence of events, or why do we get the gastric erosions in terms of their pathophysiology. The main thing is reduced blood flow, reduced perfusion, which means reduced nutrient and oxygen supply to the mucosa, which is actively normally very hypermetabolic, or metabolically more active than the rest of the wall of the stomach. The presence of the acid and pepsin inside the stomach. Acid will activate pepsin, and pepsin is an enzyme that can digest protein and lead to ulceration. As a result of reduction in the blood flow and the presence of acid, you will get the erosions because it will damage the mucosal defense mechanism. Now, this mucosal defense mechanism is well known, which is the mucus secretion. So you get reduced mucus secretion. Also, there is a reduction in the bicarbonate production in the stomach as a result of reduced perfusion. And also there is a reduction of the indigenous prostaglandin that plays a major protective role for the mucosa of the stomach to keep its viability and its constant replication. So in terms of the pathophysiology of stress ulcers, it's part of the multiple organ failure problem that could happen to the patient when they are in a major trouble, and that will lead to generalized tissue perfusion. And the gut is the second organ in the body after the skeletal-muscular system and the skin that its circulation will shut down as a result of circulatory or hemodynamic instability, whether this is caused by sepsis or bleeding or multiple trauma or otherwise. Now, we've done the endoscopy, or we looked at the coffee ground contents in the nasogastric tube. We need to treat the patient, and hopefully they would have been on prophylaxis, which I will explain in a minute. How do we treat them? Now, it really depends on the severity of the bleeding. So we will have to support the patient, multiple organ support and intensive care unit. And that could be ventilatory, circulatory, renal, hemoperfusion, and attention to their acid-base balance and electrolytes correction, and ensuring adequate tissue perfusion. So resuscitation is the main player that will help recovery or prevent the occurrence of stress gastric erosion, and the best resuscitating fluid that we can give in this situation is blood transfusion. There will always need a nasogastric decompression by itself. If you insert a nasogastric tube and decompress the stomach, it tends to reduce the intensity of the erosion and reduce the bleeding. We need to check their coagulation status by doing the prothrombin time and the APTT, and also their platelets count. And any defect in these mechanisms of coagulation should be rectified with either fresh frozen plasma if there is coagulation problem or prolonged prothrombin time, or you give them platelets if they are platelets deficient. We will institute usually infusion of proton pump inhibitors after a bolus dose, typically 40 milligrams of pantoprazole, and then they get an infusion for the first 48 hours. Experimentally, it has been shown that we need to lift the pH of the contents of the stomach to more than 5 to help prevent and treat gastric erosions. That can be done by infusion of antacids via the nasogastric tube. One of these protective mechanisms that's popular is a drug called sucralfate, and that can be given through the nasogastric tube. It covers the mucosa of the stomach in a protective way to prevent the acid and pepsin digestion. These measures will be sufficient to treat almost 95% of all patients who develop stress ulceration of the upper gastrointestinal tract. Very occasionally, if there is brisk red blood coming from the nasogastric tube or in the stomach during the endoscopy that cannot be clipped or controlled endoscopically, we ask for an angiography, and with that possibility of embolization of the left gastric artery. But I warn you, this procedure is rarely needed, and also it's really helpful because of the rich anastomosis between the left gastric artery and the other arteries that supply the stomach, the splenic, the right gastric, and the gastroepiploic artery, in addition to the blood vessels that traverses the esophagus down to the fundus of the stomach. So practically, this procedure is very unlikely to be needed. Surgery is rarely necessary in cases of hemodynamic instability where the bleeding is not controlled and cannot be controlled angiographically. The surgeon could take the patient to the operating theater, midline laparotomy, anterior gastrotomy, and suture the bleeding points. Usually patients who get to that stage, they are very unwell and they are at a very high risk of dying. Again, surgery is rarely necessary to treat this problem. Now, the most important aspect of stress ulceration is really the best way is to prevent that, and preventing that by prophylaxis and tend to be very effective. Assuming that or knowing that massive gastrointestinal bleed can happen as a result of these erosions, and it could be the fatal point that will eventually lead to demise of the patient despite the success of the rest of the treatment. In terms of treating their sepsis or their burn or their anastomotic leak. So high patients should be treated prophylactically. And as we mentioned, the high risk are the patients that we mentioned earlier, the major intervention, major surgery, major trauma, major burn. All these patients should be on PPIs, and they are very efficacious. And the efficacy of preventing upper GI bleed in patient who is on PPI reaches to 96%. And even those who bleed tend to be minor. All these patients will need, and they often are already on multiple organ support, wherever they require, from ventilation to circulatory to renal support in the intensive care units. Antibiotics play a very important role, particularly in patients with sepsis and also those with burns. We should pay an attention to nutrition of the patients. Often that will have to be parenteral, but we try to institute enteral diet via the nasogastric tube at what we call trophic level, which is 10 to 20 mils of a liquid diet that get infused via the nasogastric tube. We need to correct their acid-base balance and electrolytes, and also, as I said in the past, one of the effective methods is to introduce antacid medications via the nasogastric tube. It could be used bicarbonate simply, but sucralfate is well studied and seems to be effective. Thank you much. And I will see you in the next lesson.